Question 1. To address the challenge of ensuring vascular interventional radiography practice is aligned with the latest advancements, a radiographer encounters a recently published study suggesting a novel approach to catheter selection for a common peripheral arterial intervention that appears to offer improved procedural success rates. Which of the following actions best demonstrates a commitment to evidence-based practice and professional growth within the ARRT framework? Option A. Discussing the study's findings with experienced colleagues and the supervising physician to collaboratively assess its validity and potential integration into current protocols, while also reviewing other relevant literature. Option B. Implementing the new catheter selection method immediately in all relevant procedures without further investigation, assuming the published study guarantees superior outcomes. Option C. Dismissing the study's findings as preliminary and not yet proven, opting to wait for further validation from multiple sources before considering any changes. Option D. Continuing to use the established catheter selection method, as it has consistently yielded satisfactory results in their personal experience. Correct answer is A. Discussing the study's findings with experienced colleagues and the supervising physician to collaboratively assess its validity and potential integration into current protocols, while also reviewing other relevant literature. Explanation. This scenario presents a professional challenge because it requires a vascular interventional radiographer, VIR, to critically evaluate and integrate new research findings into their daily practice. Ensuring patient care is based on the most current and effective evidence. The challenge lies in discerning the validity and applicability of research, especially when it contradicts established protocols or personal experience. Adherence to ARRT standards and ethical principles is paramount, demanding a commitment to lifelong learning and evidence-based practice. The correct approach represents best professional practice by actively seeking, critically appraising, and applying relevant research to improve patient outcomes and procedural efficiency. This aligns with the ARRT emphasis on maintaining competence and contributing to the advancement of the profession through the use of evidence. Specifically, engaging with peer-reviewed literature, attending professional development sessions, and collaborating with peers to discuss new findings are all recognized methods for staying current and ensuring practice is informed by robust evidence. This proactive stance ensures that patient care is not only safe, but also optimized according to the latest scientific understanding, fulfilling the ethical obligation to provide the highest standard of care. An incorrect approach that relies solely on anecdotal evidence or personal experience fails to meet the standards of evidence-based practice. This approach risks perpetuating outdated or less effective techniques, potentially compromising patient safety and outcomes. It demonstrates a lack of engagement with the scientific community and a failure to uphold the professional responsibility to continuously improve practice. Another incorrect approach that dismisses new research without critical evaluation, perhaps due to resistance to change or a lack of understanding, is also professionally unacceptable. This can lead to the stagnation of practice and the missed opportunity to adopt superior methods. It signifies a failure to critically analyze information and a potential disregard for the scientific process that underpins advancements in the field. A further incorrect approach that blindly adopts new research without considering its applicability to the specific clinical setting or patient population is also problematic. While evidence-based practice encourages the use of research, it also necessitates a thoughtful integration that accounts for local resources, patient characteristics, and institutional protocols. This approach may lead to the implementation of practices that are not feasible or appropriate, potentially creating new risks. The professional decision-making process for similar situations should involve a systematic approach, identifying a clinical question or area for improvement, searching for relevant, high-quality evidence, critically appraising the evidence for its validity and applicability, integrating the evidence with clinical expertise and patient values, and evaluating the outcomes of the change. This iterative process ensures that practice remains informed, ethical, and patient-centered. Question 2. Compliance review shows that during a recent thrombectomy procedure for a lower extremity deep vein thrombosis, the radiographer did not verify the presence of the emergency resuscitation card in the immediate procedure room prior to initiating the case. Which of the following actions best reflects adherence to the ARRT standards of ethics and best practices for vascular interventional radiography in this scenario? Option A. Immediately halt the procedure until the emergency card is confirmed to be present and fully stocked. Option B. Proceed with the thrombectomy, assuming the emergency cart is readily available in the department. Option C. Request a colleague to confirm the presence of the emergency cart while the procedure is underway. Option D. Document the omission in the patient's chart and continue with the procedure. Correct answer is A. Immediately halt the procedure until the emergency cart is confirmed to be present and fully stocked. Explanation. This scenario presents a professional challenge due to the critical nature of thrombolysis and thrombectomy procedures, which directly impact patient outcomes and involve significant risk. The radiographer's role in ensuring adherence to established protocols and regulatory guidelines is paramount. Careful judgment is required to balance the urgency of the procedure with the meticulous application of safety and quality standards. The correct approach represents best professional practice because it prioritizes patient safety and procedural integrity by strictly adhering to the ARRT standards of ethics and the specific guidelines for vascular interventional radiography. This includes ensuring all necessary pre-procedural checks are completed, appropriate imaging protocols are followed, and accurate documentation is maintained. This aligns with the ARRT emphasis on competence, integrity, and patient welfare, ensuring that procedures are performed in a manner that minimizes risk and maximizes therapeutic benefit, as expected within the U.S. regulatory framework for radiologic technologists. An incorrect approach that involves proceeding with a thrombolysis procedure without confirming the availability of all necessary emergency equipment fails to uphold the ARRT standards of ethics, specifically the duty to the patient and the profession. This oversight creates a direct risk to patient safety by potentially delaying critical interventions if an emergency arises during the procedure. It also demonstrates a lack of diligence and adherence to established safety protocols, which are implicitly required for competent practice. Another incorrect approach, such as using non-standardized imaging parameters for thrombectomy without proper justification or documentation, violates the principle of maintaining professional competence and adhering to established best practices. This can lead to suboptimal imaging, potentially impacting the effectiveness of the procedure and increasing the risk of complications. It also undermines the integrity of the medical record and can hinder future analysis or quality improvement efforts. A further incorrect approach, like failing to document the administration of thrombolytic agents and the patient's response accurately, represents a failure in professional responsibility and record keeping. Accurate and complete documentation is essential for continuity of care, legal protection, and regulatory compliance. Omissions in documentation can lead to miscommunication among healthcare providers and can be viewed as a breach of professional duty. The professional reasoning process for similar situations should involve a systematic approach. First, thoroughly understanding the specific procedure and its associated risks and required protocols. Second, verifying that all necessary equipment, medications, and personnel are available and prepared. Third, meticulously following established imaging protocols and safety guidelines, documenting each step accurately. Finally, maintaining open communication with the interventionalist and the healthcare team, and proactively identifying and mitigating any potential risks to patient safety. This decision-making framework ensures that practice remains within the bounds of regulatory compliance and ethical standards. Question 3. Process analysis reveals that during a complex vascular interventional procedure, a radiologic technologist observes a subtle but concerning change in the patient's waveform morphology on the monitoring equipment, which is not immediately acknowledged by the supervising physician. The technologist has a strong clinical suspicion that this change may indicate an early sign of a hemodynamic complication. What is the most appropriate course of action for the radiologic technologist in this situation? Option A. Discreetly and professionally inform the supervising physician of the observed hemodynamic change. Option B. Immediately stop the procedure and demand that the physician address the observation. Option C. Remain silent, assuming the physician has already noted the change or that it is insignificant. Option D. Discuss the observation with other ancillary staff members before approaching the physician. The correct answer is A. Discreetly and professionally inform the supervising physician of the observed hemodynamic change. Explanation. Scenario analysis. This scenario presents an ethical dilemma where a radiologic technologist performing a vascular interventional procedure observes a subtle but potentially significant change in the patient's hemodynamics that is not immediately apparent to the supervising physician. The technologist's responsibility extends beyond simply operating equipment. It includes patient advocacy and contributing to safe patient care. The challenge lies in balancing the need to report a concern with respecting the physician's authority and avoiding unnecessary alarm or disruption to the procedure. The technologist must consider the potential consequences of both speaking up and remaining silent. Correct approach analysis. The correct approach, which involves discreetly and professionally informing the supervising physician of the observed hemodynamic change, represents best professional practice. This aligns with the ARRT standards of ethics, which emphasize the technologist's duty to act in the best interest of the patient and to maintain competence. Specifically, Standard of Conduct 1 states, radiologic technologists shall act in the best interest of the patient. Reporting a potential complication, even if subtle, directly serves this principle. Furthermore, it upholds the principle of beneficence by seeking to prevent potential harm. The technologist's role includes being an integral part of the healthcare team, contributing observations that can impact patient outcomes. Incorrect approach is analysis. Remaining silent and assuming the physician has noted the change is professionally unacceptable because it violates the duty of patient advocacy and the principle of non-maleficence. By not reporting, the technologist risks allowing a preventable complication to worsen, potentially causing harm. This inaction could be construed as a failure to uphold professional responsibilities as outlined in the ARRT standards of ethics, particularly Standard of Conduct 1. Immediately stopping the procedure and demanding the physician address the observation is also professionally unacceptable. While the intention is to protect the patient, this approach is insubordinate and disruptive. It undermines the physician's authority and the established hierarchy of the interventional suite, potentially creating a chaotic environment and compromising the procedure. This behavior does not align with professional conduct expected within a medical team. Discussing the observation with other staff members before informing the physician is professionally unacceptable. This constitutes gossip and a failure to communicate directly with the responsible party. It can lead to misinformation, anxiety among the team, and delays in addressing the patient's condition. The ARRT standards of ethics implicitly promote clear and direct communication within the healthcare team. Professional reasoning. Professionals should approach such situations by first trusting their clinical judgment and observations. The decision-making process should involve a rapid assessment of the observed change and its potential implications. The next step is to communicate the concern clearly, concisely, and respectfully to the most appropriate authority figure, in this case, the supervising physician. This communication should be factual and objective, focusing on the observed data rather than speculation. If the initial communication does not lead to a satisfactory response or resolution, the technologist should consider escalating the concern through appropriate channels, always prioritizing patient safety. Question 4. The control framework reveals that during a planned diagnostic angiography for suspected peripheral artery disease, an unexpected, significant stenosis is identified in a previously uncharacterized vessel that could be critical for collateral circulation. The interventional radiographer has completed the initial diagnostic imaging and is prepared to proceed with the planned therapeutic intervention for the known peripheral artery disease. What is the most appropriate immediate action for the interventional radiographer? Option A. Proceed with the originally planned therapeutic intervention, as the new finding is outside the scope of the initial procedure. Option B. Document the unexpected finding and complete the originally planned therapeutic intervention as scheduled. Option C. Immediately inform the supervising physician of the unexpected finding and collaboratively discuss the implications and potential changes to the planned procedure, including the need for updated consent if indicated. Option D. Attempt to treat the unexpected stenosis with the available equipment without consulting the physician, assuming it is a minor issue. The correct answer is C. Immediately inform the supervising physician of the unexpected finding and collaboratively discuss the implications and potential changes to the planned procedure, including the need for updated consent if indicated. Explanation. Scenario analysis. This scenario presents a common challenge in interventional radiology, managing patient safety and procedural integrity when unexpected findings arise during a procedure. The professional challenge lies in balancing the immediate need to address the patient's condition with the established protocols and the need for informed consent, all while operating within the strict regulatory framework governing medical practice. The radiographer must exercise critical judgment to determine the appropriate course of action without compromising patient well-being or violating regulatory guidelines. Correct approach analysis. The correct approach prioritizes patient safety and adherence to established protocols. When an unexpected finding significantly alters the planned procedure, the most responsible action is to pause, consult with the supervising physician, and reassess the situation. This includes evaluating the clinical significance of the new finding, discussing potential treatment options, and, if necessary, obtaining updated informed consent from the patient or their legal representative. This aligns with the ARRT emphasis on professional responsibility, patient care, and adherence to the scope of practice. The regulatory framework implicitly supports this by requiring practitioners to act in the best interest of the patient and to maintain competence, which includes recognizing limitations and seeking appropriate consultation. Incorrect approaches analysis. Proceeding with the original plan without addressing the new finding represents a failure to adapt to the patient's evolving condition and a potential violation of the principle of providing appropriate care. This could lead to suboptimal treatment or harm. Continuing the procedure without informing the physician or obtaining updated consent is a significant ethical and regulatory breach. It undermines the physician's ultimate responsibility for the procedure and disregards the patient's right to be informed about their care. Performing a completely different, unplanned procedure without proper consultation and consent is also a serious violation. It exceeds the scope of the initial consent and could lead to unintended consequences or complications, demonstrating a lack of professional judgment and disregard for established medical practice and patient autonomy. Professional reasoning. Professionals in vascular interventional radiography should employ a systematic decision-making process when faced with unexpected findings. This involves 1. Recognizing and accurately assessing the unexpected finding. 2. Immediately communicating the finding to the supervising physician. 3. Collaboratively discussing the clinical implications and potential management strategies. 4. Ensuring that any modifications to the procedure are adequately documented and, if necessary, that updated informed consent is obtained. 5. Adhering strictly to institutional policies and regulatory requirements throughout the process. This approach ensures patient safety, upholds ethical standards, and maintains compliance with the governing regulatory framework. Question 5. Consider a scenario where a vascular interventional radiographer is preparing for a complex angioplasty procedure. During the setup of the sterile field, a critical sterile instrument is momentarily dropped onto the floor before being retrieved. The procedure is already running slightly behind schedule, and the interventional cardiologist expresses concern about delays. What is the most appropriate course of action to ensure patient safety and maintain aseptic technique? Option A. Briefly wipe the dropped instrument with an antiseptic wipe and return it to the sterile field, as the procedure is already delayed. Option B. Immediately discard the dropped instrument and all items that may have come into contact with it, and obtain replacements to maintain the integrity of the sterile field. Option C. Allow an unscrubbed assistant to quickly rinse the dropped instrument under sterile saline and place it back into the sterile field. Option D. Continue with the procedure using the dropped instrument, assuming it was not significantly contaminated and the delay would be more detrimental. The correct answer is B. Immediately discard the dropped instrument and all items that may have come into contact with it, and obtain replacements to maintain the integrity of the sterile field. Explanation. This scenario presents a common challenge in vascular interventional radiography, maintaining strict aseptic technique during a complex procedure while facing potential disruptions. The professional challenge lies in balancing the need for efficiency with the paramount importance of patient safety and infection prevention, as mandated by ARRT standards and Centers for Medicare and Medicaid Services, CMS, guidelines, which emphasize adherence to established protocols. The correct approach represents best professional practice because it prioritizes patient well-being and adherence to regulatory requirements for infection control. This involves meticulous preparation, including confirming the sterility of all instruments and supplies, performing a thorough surgical hand scrub, and donning sterile personal protective equipment, PPE, correctly. The use of a sterile drape to create a sterile field and the continuous monitoring of the field's integrity are critical steps to prevent microbial contamination, directly aligning with guidelines from the Centers for Disease Control and Prevention, CDC, on preventing healthcare-associated infections, high. An incorrect approach involving the reuse of a partially used sterile drape would be a significant regulatory and ethical failure. This action directly violates aseptic technique principles and increases the risk of introducing pathogens into the sterile field, potentially leading to a serious patient infection. Such a breach would contraindicate ARRT ethical standards, which require radiographers to act in the best interest of the patient and uphold professional conduct. Another incorrect approach, such as proceeding with the procedure without a complete sterile field due to a perceived time constraint, demonstrates a disregard for patient safety and a failure to follow established infection control protocols, which are foundational to safe medical practice and are implicitly or explicitly required by regulatory bodies overseeing healthcare quality. A third incorrect approach, such as allowing an unscrubbed assistant to handle sterile instruments, also compromises the sterile field and violates aseptic technique, posing a direct risk to the patient and failing to meet the professional standards expected of a certified radiographer. The professional decision-making process in such situations should involve a systematic evaluation of the situation against established protocols and ethical guidelines. Radiographers must be empowered to pause or halt a procedure if aseptic technique is compromised, prioritizing patient safety over perceived time pressures. This requires a strong understanding of infection control principles, a commitment to ethical practice, and the ability to communicate effectively with the healthcare team to ensure adherence to best practices. Question 6. The investigation demonstrates diffuse, irregular enhancement within a segment of the bowel wall on contrast-enhanced imaging, with associated delayed washout of contrast material. This pattern is suggestive of compromised microcirculation and capillary network dysfunction. Considering the ARRT-VI certification scope, which of the following interpretations best reflects the potential underlying pathology at the microcirculatory level? Option A, venous congestion and stasis due to obstruction of venous outflow. Option B, extrinsic compression of the bowel wall by a mass lesion. Option C, focal arterial occlusion causing complete cessation of blood flow to the affected tissue. Option D, increased capillary permeability and impaired lymphatic drainage leading to interstitial edema and reduced perfusion. The correct answer is D, increased capillary permeability and impaired lymphatic drainage leading to interstitial edema and reduced perfusion. Explanation. The investigation demonstrates a complex scenario involving microcirculation and capillary networks, requiring a radiographer to integrate knowledge of physiological processes with imaging techniques. The professional challenge lies in accurately interpreting imaging findings that reflect alterations in capillary function and flow, and then applying this interpretation to guide patient management within the scope of vascular interventional radiography. This requires a deep understanding of how various pathologies manifest at the microcirculatory level and how different imaging modalities can visualize these changes. The correct approach represents best professional practice because it directly addresses the observed findings by correlating them with known pathophysiological mechanisms affecting microcirculation. This aligns with the ARRT-VI certification's emphasis on understanding the application of imaging in vascular disease. Specifically, it requires the radiographer to apply their knowledge of capillary dynamics, such as permeability and flow, to interpret the imaging data. This interpretation is crucial for informing the interventionalist about the extent and nature of the vascular compromise, which is a core responsibility in this specialty. Adherence to established protocols and the radiologist's interpretation is paramount, ensuring patient safety and diagnostic accuracy, which are fundamental ethical and regulatory obligations. An incorrect approach that focuses solely on gross anatomical changes without considering the microcirculatory implications fails to provide a complete picture of the vascular disease. This oversight can lead to incomplete or inaccurate assessments, potentially impacting treatment decisions. From a regulatory standpoint, this represents a failure to fully utilize the diagnostic capabilities of the imaging modality and a deviation from the expected level of expertise for a VI-certified professional. Another incorrect approach that prioritizes a single imaging parameter without considering the broader physiological context of microcirculation is also professionally unacceptable. Microcirculation is a dynamic system, and isolated findings may be misleading. A comprehensive interpretation requires integrating multiple pieces of information. Ethically, this could lead to misdiagnosis or suboptimal treatment planning, potentially harming the patient. Finally, an approach that disregards the need for correlation with clinical presentation and other diagnostic data is flawed. Imaging findings must always be interpreted within the patient's overall clinical picture. Failing to do so can result in misinterpretations and inappropriate interventions, violating the principle of beneficence and non-maleficence in patient care. This also represents a failure to adhere to best practices in diagnostic imaging, which mandate a holistic approach to patient assessment. The professional decision-making process for similar situations should involve a systematic evaluation of the imaging findings, a thorough understanding of the underlying pathophysiology of microcirculation as it relates to the suspected condition, and a collaborative approach with the interpreting physician. Radiographers must continuously update their knowledge of vascular physiology and imaging techniques to effectively contribute to patient care. Question 7. Upon reviewing the fluoroscopic imaging parameters for a complex peripheral angiography, a radiologic technologist notes that the cumulative air kerma dose displayed on the unit is approaching a threshold that warrants notification according to institutional policy. The procedure is still ongoing and requires further imaging to adequately visualize critical anatomy. Which of the following actions best demonstrates adherence to radiation safety and dose management principles within the ARRT certification framework? Option A. Immediately cease fluoroscopy and proceed with image acquisition using static radiography to minimize further fluoroscopic dose, even if it compromises real-time guidance for the remainder of the procedure. Option B. Continue fluoroscopy at the current settings, assuming the displayed dose is an estimate and the actual dose to the patient will be within acceptable limits, while informing the supervising physician of the approaching threshold. Option C. Adjust fluoroscopic settings to a lower frame rate. Utilize pulsed fluoroscopy if available, optimize collimation to the area of interest, and continue the procedure while closely monitoring dose indicators and communicating with the supervising physician. Option D. Request the supervising physician to immediately terminate the procedure due to the approaching dose threshold, regardless of the clinical necessity for further imaging. Correct answer is A. Immediately cease fluoroscopy and proceed with image acquisition using static radiography to minimize further fluoroscopic dose, even if it compromises real-time guidance for the remainder of the procedure. Explanation. The scenario presents a common challenge in interventional radiology, balancing the need for optimal imaging to guide complex procedures with the imperative to minimize radiation exposure to both the patient and the staff. This requires a nuanced understanding of radiation safety principles and their practical application within the regulatory framework governing medical imaging in the United States, as defined by the ARRT for Vascular Interventional Radiography (VI) certification. The professional challenge lies in making real-time decisions that prioritize patient safety and diagnostic efficacy without compromising staff well-being, all while adhering to established dose management strategies. The correct approach emphasizes a proactive and systematic application of ARRT as low as reasonably achievable principles, integrated with specific technical and procedural adjustments. This aligns directly with the fundamental tenets of radiation safety mandated by regulatory bodies such as the Nuclear Regulatory Commission, NRC, and the Food and Drug Administration, FDA, which are foundational to ARRT certification. Best professional practice involves utilizing collimation, appropriate filtration, pulsed fluoroscopy, and optimizing image acquisition parameters to reduce dose without sacrificing diagnostic quality. Furthermore, employing dose monitoring tools and understanding the cumulative dose implications are critical components of responsible practice. Incorrect approaches fail to adequately address the multifaceted nature of radiation safety. One incorrect approach might prioritize speed or convenience over dose reduction, leading to unnecessary radiation exposure. This violates the ARRT principle and potentially exceeds established dose limits, which are outlined in regulations and guidelines that ARRT certification exams are based upon. Another incorrect approach might involve neglecting to utilize available dose reduction technologies or failing to implement appropriate shielding, thereby increasing exposure risks. Such oversights represent a failure to adhere to best practices and regulatory requirements for radiation protection. A third incorrect approach could involve a lack of awareness or understanding of patient-specific factors that influence dose, such as patient size or condition, leading to suboptimal dose management. This demonstrates a deficiency in applying radiation safety principles in a personalized and effective manner. The professional decision-making process in such situations should involve a continuous assessment of the imaging needs versus the radiation dose implications. This includes pre-procedure planning to anticipate potential dose challenges, real-time monitoring of dose indicators during the procedure, and post-procedure review to evaluate the effectiveness of dose management strategies. Professionals must be proficient in operating imaging equipment in a manner that minimizes dose, understand the physics of radiation interaction with tissue, and be aware of the regulatory landscape governing radiation safety in the United States. Question 8. System analysis indicates that during a lower extremity venous intervention, the radiographer is tasked with identifying the origin of a superficial venous anomaly. Which of the following anatomical landmarks is most crucial for accurately differentiating between the great saphenous vein and its proximal tributaries before confluence with the deep venous system? Option A, the adductor canal. Option B, the popliteal fossa. Option C, the inguinal ligament. Option D, the femoral triangle. The correct answer is A, the adductor canal. Explanation: scenario analysis. This scenario presents a professional challenge by requiring the radiographer to apply detailed anatomical knowledge of the vascular system in a dynamic, clinical context. The challenge lies in accurately identifying and differentiating between various venous structures within the lower extremity, particularly when subtle variations or pathology might be present. This demands not only memorization of anatomical facts, but also the ability to visualize and interpret these structures in real time during an interventional procedure, ensuring patient safety and procedural efficacy. Correct approach analysis. The correct approach involves a thorough understanding of the venous anatomy of the lower extremity, specifically recognizing the saphenous vein system and its tributaries. This includes knowing the typical course and branching patterns of the great saphenous vein, GSV, and small saphenous vein, SSV, as well as their common points of confluence with the deep venous system. In the context of vascular interventional radiography, precise anatomical identification is paramount for safe catheter and guide wire manipulation, accurate contrast injection, and effective treatment of venous pathology. Adherence to ARRT standards for vascular interventional radiography certification necessitates this level of anatomical expertise, ensuring that the radiographer can contribute effectively to patient care and procedural success within the established regulatory framework. Incorrect approaches analysis. One incorrect approach would be to rely solely on a general understanding of venous flow without specific knowledge of the saphenous vein network. This could lead to misidentification of target vessels, potentially resulting in incorrect access, suboptimal treatment delivery, or inadvertent injury to adjacent structures. Such a failure to demonstrate specific anatomical knowledge directly contravenes the expected competency for ARRT certification in VI. Another incorrect approach would be to confuse the superficial venous system with the deep venous system. The management and intervention strategies for these two systems differ significantly. Mistaking a superficial vein for deep vein could lead to inappropriate procedural planning, potentially compromising the integrity of the deep venous system, which is crucial for overall venous return. This demonstrates a critical deficiency in anatomical understanding, which is a fundamental requirement for safe practice in vascular interventional radiography. A third incorrect approach would be to prioritize procedural speed over anatomical accuracy. While efficiency is important, it should never come at the expense of precise anatomical identification. Rushing through the identification process without confirming the exact location and characteristics of the target vein could lead to serious complications, such as vessel perforation or embolization of unintended structures. This disregard for anatomical detail represents a failure to uphold the professional standards of care and the ethical obligations inherent in patient management. Professional reasoning. Professionals in vascular interventional radiography must employ a systematic approach to anatomical identification. This involves integrating knowledge from anatomical texts, imaging modalities, such as ultrasound and fluoroscopy, and procedural context. When faced with anatomical identification challenges, the decision-making process should prioritize patient safety and procedural success. This includes 1. Confirming anatomical landmarks. 2. Utilizing multiple imaging planes and techniques to triangulate the target structure. 3. Consulting with the interventionalist if there is any uncertainty. and 4. Cross-referencing findings with established anatomical references. This rigorous, safety-conscious approach ensures that interventions are performed on the correct anatomy, minimizing risks and maximizing therapeutic benefit, in full compliance with ARRT certification requirements. Question 9. Examination of the data shows a patient with a history of right subclavian artery occlusion, requiring a vascular interventional procedure necessitating left upper extremity venous access. Pre-procedural imaging confirms the right subclavian occlusion, but does not provide detailed visualization of the left axillary and brachial veins. Given these findings, what is the most appropriate initial approach for venous access? Option A. Attempt venous access via the right subclavian vein, assuming collateral circulation will compensate. Option B. Attempt venous access via the left axillary vein after reviewing available imaging for collateral flow and vein patency. Option C. Proceed directly with arterial access in the contralateral limb, such as the right common femoral artery, as a primary strategy. Option D. Proceed with venous access in the left upper extremity, without specific imaging of the axillary and brachial veins, assuming they are patent. Correct answer is B. Attempt venous access via the left axillary vein after reviewing available imaging for collateral flow and vein patency. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in vascular interventional radiography, identifying and managing anatomical variations. The patient's history of a right subclavian artery occlusion and the need for left upper extremity access for a complex procedure necessitate a thorough understanding of potential collateral pathways and alternative venous access routes. Failure to accurately assess these variations can lead to procedural complications, including inadequate imaging, vessel injury, prolonged procedure times, and patient harm. The professional challenge lies in integrating pre-procedural imaging findings with real-time intraprocedural assessment to ensure safe and effective treatment. Correct approach analysis. The correct approach involves a comprehensive review of pre-procedural imaging, specifically focusing on the collateral circulation from the left subclavian artery and the patency of the left axillary and brachial veins. This detailed anatomical understanding allows for the selection of the most appropriate access site and the anticipation of potential challenges. Utilizing the left axillary vein, given its likely patency and direct drainage from the left upper extremity, is the preferred strategy. This approach aligns with the ARRT emphasis on patient safety and the radiographer's responsibility to contribute to a successful diagnostic and therapeutic outcome by understanding relevant anatomy and potential deviations. It demonstrates a commitment to evidence-based practice and patient-centered care, ensuring the procedure is performed with the least risk and greatest efficacy. Incorrect approach is analysis. Attempting to access the right subclavian vein despite the known occlusion would be a direct contravention of safe practice. This approach ignores critical pre-procedural data, increasing the risk of failed access, vessel damage, and potentially exacerbating the existing occlusion or causing new complications. It represents a failure to adhere to the fundamental principle of using available diagnostic information to guide patient care. Proceeding with left upper extremity venous access without a thorough assessment of the axillary and brachial veins, or assuming they are patent, is also an unacceptable approach. While the left subclavian occlusion is noted, the status of the downstream veins is unknown without specific imaging review. This could lead to failed venous access, deep vein thrombosis, or embolization if a thrombus is present and dislodged. It demonstrates a lack of due diligence in pre-procedural planning. Choosing to proceed with arterial access in the contralateral limb e.g., right common femoral artery, without first attempting venous access in the left upper extremity, especially when left upper extremity venous access is indicated for the specific procedure, is also suboptimal. While alternative arterial access might be considered if venous access fails, it bypasses a potentially less invasive and more direct route for the intended procedure, increasing procedural complexity and risk without sufficient justification based on the provided data. This approach fails to prioritize the most appropriate and least invasive access method indicated by the procedural requirements and anatomical considerations. Professional reasoning. Professionals should employ a systematic decision-making framework that begins with a thorough review of all available patient data, including medical history, physical examination findings, and all imaging studies. This is followed by an assessment of the procedural requirements and the identification of potential anatomical variations that could impact access or the procedure itself. Based on this comprehensive understanding, the safest and most effective access strategy should be formulated, with contingency plans in place for anticipated challenges. Continuous intraprocedural assessment and adaptation are crucial, always prioritizing patient safety and adhering to established protocols and ethical guidelines. Question 10. Performance analysis shows that a vascular interventional radiographer is preparing for a complex arterial embolization procedure. To ensure optimal patient outcomes and procedural safety, which aspect of the circulatory system's function is most critical for the technologist to thoroughly understand in this context? Option A. The precise pressure gradients within the peripheral venous system. Option B. The electrical conduction system of the heart. Option C. The direction of blood flow through the targeted arterial branches and their collateral pathways. Option D. The lymphatic drainage patterns of the affected limb. The correct answer is A. The precise pressure gradients within the peripheral venous system. Explanation. The scenario presents a common challenge in vascular interventional radiography, ensuring accurate patient care and procedural success by understanding the fundamental anatomy and physiology of the circulatory system. Misinterpreting or lacking a comprehensive understanding of these principles can lead to procedural errors, suboptimal outcomes, and potential patient harm. The ARRT certification exam emphasizes this foundational knowledge because it directly impacts the technologist's ability to perform procedures safely and effectively. The correct approach demonstrates best professional practice by prioritizing a thorough understanding of the circulatory system's role in vascular interventions. This includes recognizing how different vessels are accessed, the direction of blood flow, and the potential impact of interventions on systemic circulation. This aligns with the ARRT certification's focus on applying knowledge to clinical practice, ensuring technologists can anticipate procedural challenges and contribute to positive patient outcomes. Adherence to established anatomical and physiological principles is implicitly required by the ARRT standards for competency. An incorrect approach that focuses solely on the immediate procedural steps without considering the broader circulatory context fails to meet the expected level of understanding for a certified VI technologist. This could lead to overlooking potential complications related to blood flow dynamics or anatomical variations, which are critical for safe and effective intervention. Such a deficiency would represent a failure to demonstrate the comprehensive knowledge base required by the ARRT, potentially leading to suboptimal patient care. Another incorrect approach might involve relying on rote memorization of specific procedures without understanding the underlying physiological rationale. This limits adaptability and problem-solving capabilities when faced with unexpected anatomical presentations or procedural deviations. The ARRT expects technologists to possess a conceptual understanding that allows for critical thinking and informed decision-making, not just the ability to follow a script. A third incorrect approach could be to disregard the importance of venous anatomy when the primary focus is arterial access. While many interventions target arterial disease, understanding the venous system is crucial for managing access sites, potential complications, and certain types of interventions. A superficial understanding of the circulatory system, neglecting significant components, is a direct failure to meet the comprehensive knowledge requirements for VI certification. The professional reasoning process for similar situations should involve a continuous self-assessment of knowledge gaps. Before and during procedures, technologists should mentally review the relevant anatomy and physiology, considering how the planned intervention interacts with the circulatory system. This proactive approach, grounded in a deep understanding of the circulatory system, is essential for anticipating challenges, communicating effectively with the interventionalist, and ensuring patient safety. Question 11. The evaluation methodology shows a radiographer is preparing for a complex endovascular repair of an abdominal aortic aneurysm. Which of the following anatomical considerations presents the highest immediate risk during access and deployment of the stent graft, requiring the most critical risk assessment? Option A. The origin and proximal extent of the common iliac arteries and their relationship to the infrarenal abdominal aorta. Option B. The diameter of the popliteal artery and its suitability for sheath insertion. Option C. the patency of the superficial femoral vein and its potential for thrombus formation. Option D, the presence of significant atherosclerotic plaque within the common femoral artery. Correct answer is D, the presence of significant atherosclerotic plaque within the common femoral artery. Explanation. The evaluation methodology shows a need to assess a radiographer's understanding of major arterial and venous anatomy in the context of vascular interventional procedures, specifically focusing on risk assessment. This scenario is professionally challenging because accurate anatomical knowledge is paramount for patient safety, procedural success, and the avoidance of complications. Misidentification or misunderstanding of major vessels can lead to inadvertent injury, hemorrhage, or suboptimal treatment delivery, all of which carry significant ethical and regulatory implications under ARRT guidelines. The correct approach represents best professional practice because it demonstrates a comprehensive understanding of the anatomical relationships and potential risks associated with interventions in the abdominal aorta and its major branches. This includes recognizing the critical nature of the aorta as the primary conduit for oxygenated blood and understanding the potential consequences of injury, such as massive hemorrhage. It also involves considering the branching patterns of the iliac arteries and their significance for access and potential complications. This aligns with the ARRT emphasis on the radiographer's role in patient care and safety, requiring a thorough knowledge base to anticipate and mitigate risks. An incorrect approach that focuses solely on the superficial femoral artery without considering the proximal aorta and iliacs is professionally unacceptable. This represents a failure to grasp the systemic implications of vascular interventions. The regulatory failure lies in not demonstrating the required depth of anatomical knowledge for complex interventional procedures, potentially leading to inadequate risk assessment and patient harm. Another incorrect approach that prioritizes venous anatomy over arterial for an arterial intervention is also a significant regulatory and ethical failure. It indicates a fundamental misunderstanding of the procedure's target anatomy and the associated risks, violating the ARRT standards for competency and patient safety. A third incorrect approach that overlooks the potential for collateral circulation in favor of a single vessel path fails to acknowledge the dynamic nature of vascular anatomy and its impact on procedural planning and risk. This demonstrates a lack of comprehensive anatomical understanding necessary for effective interventional radiography. The professional reasoning process for similar situations should involve a systematic approach to anatomical review, considering the primary target vessel, its origin, major branches, and potential collateral pathways. Radiographers must continuously assess the risks associated with each anatomical variation and procedural step, integrating this knowledge with imaging findings and clinical context. This proactive risk assessment, grounded in a robust understanding of vascular anatomy, is essential for upholding the highest standards of patient care and adhering to regulatory requirements. Question 12. Analysis of a vascular interventional procedure reveals that the initial radiographic technique resulted in an underexposed image with poor visualization of small vessels. The radiographer considers adjusting the technical factors to improve image quality. Which of the following adjustments, based on the fundamental principles of radiography, would best improve image quality while adhering to radiation safety principles? Option A. Decrease the source-to-image receptor distance (SID) to improve image sharpness. Option B. Significantly increase the milliampere-seconds M as without adjusting kilovoltage kVp or other factors. Option C. Increase the kilovoltage kVp while decreasing the milliampere-seconds M as proportionally to maintain exposure and ensure appropriate collimation. Option D. Rely solely on the automatic exposure control (EEC) to automatically adjust all parameters for the next exposure. Correct answer is C. Increase the kilovoltage kVp while decreasing the milliampere-seconds M as proportionally to maintain exposure and ensure appropriate collimation. Explanation. The scenario presents a common challenge in vascular interventional radiography, ensuring optimal image quality for diagnostic purposes while minimizing patient radiation dose. This requires a deep understanding of the fundamental principles of radiography, specifically how technical factors influence image characteristics and radiation exposure. The ARRT VI certification exam emphasizes the radiographer's responsibility to produce diagnostic images efficiently and safely, adhering to established standards and guidelines. The correct approach demonstrates best professional practice by prioritizing patient safety and diagnostic efficacy through informed technique selection. This aligns with the core principles of ARRT, as low as reasonably achievable, and the ARRT ethical standards, which mandate competent practice and patient well-being. Specifically, understanding the inverse square law and the relationship between KVP, M as distance and filtration is crucial for making appropriate adjustments. Incorrect approaches fail to uphold these professional and regulatory obligations. Selecting a technique that significantly increases radiation dose without a commensurate improvement in diagnostic image quality is a direct violation of ARRT. Similarly, choosing a technique that compromises image quality to the point of hindering diagnosis is professionally unacceptable, as it fails to meet the primary objective of the procedure. Relying solely on automatic exposure control (EEC), without understanding its limitations or the underlying radiographic principles, can lead to suboptimal exposures and unnecessary dose, especially in complex interventional procedures where anatomy varies greatly. The professional decision-making process in such situations involves a systematic evaluation of the patient's anatomy, the procedural requirements, and the available equipment. It necessitates a thorough understanding of the interplay between technical factors and their impact on image receptor exposure, contrast, spatial resolution, and patient dose. Radiographers must be able to anticipate potential challenges and proactively adjust parameters to achieve the desired diagnostic outcome with the lowest possible radiation exposure. This involves critical thinking, application of learned principles, and a commitment to continuous learning and adherence to professional standards. Question 13. Market research demonstrates a growing demand for advanced imaging techniques in vascular interventional procedures. During a complex peripheral angioplasty, the interventional radiographer needs to visualize guidewire manipulation within tortuous vessels and assess contrast opacification. Which imaging approach best balances diagnostic image quality with radiation dose reduction for this scenario? Adhering to ARRT-VI certification standards. Option A. Utilizing continuous fluoroscopy at the highest available frame rate to ensure immediate visualization of all movements. Option B. Employing pulsed fluoroscopy at a low frame rate, e.g., 4-7 pulses per second, with appropriate collimation to the area of interest. Option C. Relying solely on static digital subtraction angiography, DSA, images without real-time fluoroscopic guidance. Option D. Maximizing the X-ray beam's field of view to encompass the entire patient's torso for comprehensive coverage. The correct answer is B. Employing pulse fluoroscopy at a low frame rate, e.g., 4-7 pulses per second, with appropriate collimation to the area of interest. Explanation. This scenario presents a common challenge in interventional radiography where patient anatomy and procedural complexity necessitate careful consideration of imaging techniques to optimize diagnostic information while minimizing radiation exposure. The professional challenge lies in balancing the need for clear visualization of critical structures, such as guidewire position and contrast flow, with the ARRT principle and the specific requirements of the vascular interventional radiography VI certification, which emphasizes safe and effective patient care. The correct approach represents best professional practice because it prioritizes patient safety and diagnostic efficacy by selecting an imaging technique that directly addresses the procedural need for detailed visualization of vascular anatomy and device placement. This aligns with the ARRT-VI content specifications, which require understanding of various imaging modalities and their application in interventional procedures. Specifically, utilizing pulse fluoroscopy with a low frame rate is a standard technique to reduce radiation dose while maintaining adequate image quality for real-time guidance. The judicious use of collimation further minimizes scatter radiation to the patient and staff. Adhering to regulatory guidelines for radiation protection. An incorrect approach that relies solely on continuous fluoroscopy at a high frame rate would fail to adequately address radiation dose reduction, potentially violating the ARRT principle and exceeding acceptable exposure limits without a clear clinical justification. This demonstrates a lack of understanding of dose-saving techniques crucial for interventional procedures. Another incorrect approach that neglects collimation would increase scatter radiation, posing a greater risk to both the patient and the interventional team, and failing to meet established safety standards. A third incorrect approach that prioritizes image acquisition speed over diagnostic quality, such as using a very low MA setting without compensating for potential image degradation, could lead to suboptimal visualization of critical anatomical structures and device placement, potentially compromising the safety and effectiveness of the procedure and requiring repeat imaging, thus increasing overall radiation dose. The professional decision-making process in such situations should involve a systematic evaluation of the procedural requirements, patient factors, and available imaging technologies. This includes understanding the trade-offs between image quality, frame rate, radiation dose, and the specific information needed for safe and effective intervention. Radiographers should consult established protocols, consider the ARRT principle, and utilize their knowledge of imaging physics and interventional techniques to select the most appropriate imaging parameters. Question 14. The monitoring system demonstrates a patient presenting for a peripheral angiography with a serum creatinine of 1.8 mg/dl and an eGFR of 35 ml/min/1.73 m2. The procedure requires detailed visualization of the arterial vasculature. Which of the following represents the most appropriate course of action regarding iodinated contrast media administration? Option A. Proceed with the iodinated contrast administration as scheduled, as the eGFR is not severely impaired and the diagnostic information is critical for the planned intervention. Option B. Decline to administer iodinated contrast media and suggest a non-contrast CT angiography, acknowledging that image quality may be suboptimal for detailed vascular assessment. Option C. Administer a reduced volume of iodinated contrast media to minimize nephrotoxicity, even if it compromises the diagnostic quality of the images. Option D. Administer iodinated contrast media with aggressive pre- and post-hydration protocols, and consider the use of a low-osmolar or iso-osmolar contrast agent, after consultation with the interpreting physician, to weigh the procedural necessity against the renal risk. Correct answer is D. Administer iodinated contrast media with aggressive pre- and post-hydration protocols, and consider the use of a low-osmolar or iso-osmolar contrast agent, after consultation with the interpreting physician, to weigh the procedural necessity against the renal risk. Explanation. This scenario presents a common clinical challenge in vascular interventional radiography, balancing the diagnostic necessity of iodinated contrast media with the potential risks to patients with compromised renal function. The ARRT certification in vascular interventional radiography, VI, emphasizes the radiographer's role in patient safety and adherence to established protocols. Therefore, understanding the indications and contraindications for contrast use, particularly in the context of renal insufficiency, is paramount. The correct approach involves a thorough assessment of the patient's renal function and a careful consideration of the risks versus benefits of contrast administration. This aligns with the ARRT focus on professional responsibility and patient care, requiring radiographers to be knowledgeable about contraindications and to collaborate with the interpreting physician. The decision to proceed with contrast, or to seek alternatives, must be based on a comprehensive evaluation of the patient's clinical status and the specific procedural requirements, always prioritizing patient safety as dictated by professional standards and institutional guidelines, which are implicitly guided by regulatory frameworks like those overseen by the FDA for contrast agents and professional practice standards. Incorrect approaches fail to adequately address the patient's renal status or the potential for contrast-induced nephropathy. Sin. Administering contrast without a proper risk assessment, or without considering alternative imaging modalities or prophylactic measures, violates the principle of do no harm and can lead to significant patient morbidity. This demonstrates a failure to adhere to best practices in patient management and may contravene guidelines for the safe use of contrast media, which are informed by regulatory bodies and professional organizations. The professional decision-making process in such situations requires a systematic approach. 1. Patient assessment. Thoroughly review the patient's medical history, including pre-existing renal disease, medications, and laboratory values, e.g., serum creatinine, estimated glomerular filtration rate, eGFR. 2. Risk-benefit analysis. Evaluate the necessity of the contrast-enhanced imaging procedure for diagnosis or intervention against the potential risks of CIN. 3. Consultation. If renal function is compromised, consult with the referring physician or radiologist to discuss alternative imaging techniques, e.g., non-contrast imaging, ultrasound, MRI with gadolinium if appropriate and safe, or strategies to mitigate CIN risk, e.g., hydration-specific medications. 4. Informed consent. Ensure the patient understands the risks and benefits of contrast administration. 5. Protocol adherence. Follow institutional protocols for contrast administration in patients with renal insufficiency. Question 15. Research into the selection of guide wires and catheters for a complex femoropopliteal artery stenosis intervention reveals several potential strategies. Which strategy best aligns with the principles of safe and effective patient care within the ARRT certification framework? Option A. Utilizing a standard, rigid guide wire and a straight-tip catheter to simplify manipulation, regardless of the specific anatomical challenges presented by the stenosis. Option B. Choosing a guide wire with a hydrophilic coating and a tapered tip, paired with a catheter that offers good torque control and a suitable curve for navigating tortuous anatomy, after a thorough review of patient imaging and lesion characteristics. Option C. Selecting a guide wire and catheter combination that has been historically used by the primary interventionalist for similar cases, prioritizing ease of use and familiarity. Option D. Opting for the smallest diameter guide wire and catheter that can technically pass through the lesion, with the assumption that this will minimize vessel trauma. The correct answer is C. Selecting a guide wire and catheter combination that has been historically used by the primary interventionalist for similar cases, prioritizing ease of use and familiarity. Explanation. This scenario presents a professional challenge due to the critical nature of guide wire and catheter selection in vascular interventional radiography, VIR. The ARRT certification in VIR requires a thorough understanding of how device selection directly impacts patient safety, procedural success, and adherence to established best practices, which are implicitly governed by regulatory frameworks emphasizing patient well-being and competent practice. The challenge lies in balancing anatomical considerations, lesion characteristics, and patient factors with the available device technology to achieve the desired therapeutic outcome while minimizing risks. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based selection process aligned with the principles of patient care and procedural efficacy. This involves a comprehensive assessment of the patient's anatomy, the specific pathology being treated, and the intended intervention. Selecting a guide wire and catheter that are appropriately sized, have the correct tip configuration, and possess the necessary torque and pushability ensures optimal navigation through complex vasculature, reduces the risk of vessel trauma, and facilitates accurate device deployment. This aligns with the implicit regulatory expectation of providing safe and effective patient care, as mandated by professional standards and guidelines that underpin ARRT certification. An incorrect approach, such as selecting a guide wire and catheter based solely on personal preference or convenience, represents a significant regulatory and ethical failure. This disregard for patient-specific factors and procedural requirements can lead to increased fluoroscopy time, potential vessel injury, e.g., dissection, perforation, suboptimal treatment delivery, and prolonged procedure times, all of which compromise patient safety. Such an approach fails to meet the standard of care expected of a certified VIR professional and could be considered negligent. Similarly, choosing a device without considering its compatibility with other imaging modalities or interventional tools could lead to procedural complications and a failure to achieve the intended therapeutic goals, again violating the implicit duty of care. The professional decision-making process for similar situations should involve a structured approach. First, thoroughly review the patient's medical history and imaging studies to understand the vascular anatomy and pathology. Second, identify the specific goals of the intervention. Third, consider the characteristics of available guide wires and catheters, evaluating their tip shape, stiffness, length, diameter, and trackability in relation to the target anatomy and lesion. Fourth, consult with the supervising physician to confirm the chosen devices are appropriate. Finally, document the rationale for device selection in the patient's medical record, ensuring transparency and accountability. This systematic process ensures that decisions are patient-centered, evidence-based, and compliant with the highest standards of professional practice. Question 16. Quality control measures reveal an intermittent warning light on the angiography unit's power injector during a complex interventional procedure, The physician is actively engaged in a critical part of the intervention. What is the most appropriate immediate action for the vascular interventional radiographer? Option A. Proceed with the intervention, but document the warning light in the patient's chart without taking any immediate action. Option B. Attempt to troubleshoot the warning light discreetly while the physician continues the intervention to avoid disrupting the workflow. Option C. Immediately pause the procedure, inform the physician of the warning light and its potential implications, and initiate documented troubleshooting protocols. Option D. Continue the procedure as planned, assuming the warning light is a minor glitch that will resolve itself. Correct answer is C. Immediately pause the procedure, inform the physician of the warning light and its potential implications, and initiate documented troubleshooting protocols. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in vascular interventional radiography, ensuring patient safety during a procedure when a potential equipment malfunction is identified. The challenge lies in balancing the immediate need for the procedure to continue with the paramount responsibility of patient well-being and adherence to regulatory standards. The technologist must make a rapid, informed decision without compromising patient care or violating established protocols. Correct approach analysis. The correct approach prioritizes patient safety and regulatory compliance by immediately halting the procedure and initiating a documented troubleshooting process. This aligns with ARRT standards and general patient care ethics, which mandate that any suspected equipment malfunction that could compromise patient safety or diagnostic accuracy must be addressed before proceeding. The ARRT Code of Ethics, specifically Principle Roman II, states that radiologic technologists shall act in the best interests of the patient. This includes ensuring that all equipment used is functioning correctly and safely. Furthermore, regulatory guidelines, such as those from the FDA concerning medical device reporting and quality control, necessitate reporting and addressing potential device failures. Documenting the issue and the steps taken is crucial for accountability, future reference, and potential regulatory review. Incorrect approaches analysis. Continuing the procedure without addressing the suspected malfunction is a direct violation of patient safety principles and ethical obligations. It exposes the patient to potential harm from an unreliable device, which could lead to inaccurate imaging, prolonged procedure times, or even direct injury. This approach disregards the ARRT Code of Ethics, particularly Principle Roman II, and potentially violates FDA regulations regarding the use of medical devices. Attempting to troubleshoot the equipment while the procedure is ongoing, without first pausing and ensuring patient stability and safety, is also unacceptable. This could lead to a compromised procedure, increased risk to the patient, and a failure to adequately diagnose or treat the patient's condition. It demonstrates a lack of adherence to established safety protocols and a disregard for the potential consequences of a malfunctioning device during an invasive procedure. Ignoring the warning light and proceeding as if it were a minor, non-critical issue is negligent. Warning lights and system alerts are designed to indicate potential problems that require attention. Dismissing such indicators without proper investigation is a failure to exercise due diligence and professional judgment, potentially leading to severe patient harm and a breach of professional responsibility. Professional reasoning. Professionals facing such a situation should employ a systematic decision-making framework. First, recognize and acknowledge the warning signal as a potential safety concern. Second, immediately assess the immediate risk to the patient. In this case, a suspected malfunction during an interventional procedure poses a significant risk. Third, consult established protocols for equipment malfunction. This typically involves pausing the procedure, informing the physician, and initiating a documented troubleshooting process. Fourth, prioritize patient safety above all else. If the equipment cannot be quickly and safely verified as functional, the procedure should be aborted or postponed until the issue is resolved. Finally, ensure thorough documentation of the event, the troubleshooting steps, and the final decision. Question 17. Governance review demonstrates a need to enhance the technologist's role in proactive risk mitigation during radiographic imaging for vascular interventional procedures. Considering the ARRT VI certification requirements and U.S. federal and state radiation safety regulations, which of the following approaches best exemplifies a risk assessment strategy to optimize patient care and radiation safety prior to initiating an imaging sequence? Option A. Implementing a standardized imaging protocol for all patients undergoing similar vascular interventional procedures, relying on the radiologist's interpretation to identify any suboptimal image quality. Option B. Conducting a pre-procedural assessment of patient anatomy, procedural requirements, and potential for radiation-induced harm to tailor imaging parameters and minimize dose while ensuring diagnostic image quality. Option C. Prioritizing rapid image acquisition by utilizing the highest available fluoroscopic frame rate and shortest exposure times, assuming this inherently minimizes patient dose. Option D. Relying solely on the imaging equipment's automatic exposure control (EC) system to manage all radiographic parameters without technologist intervention or assessment. The correct answer is A. Implementing a standardized imaging protocol for all patients undergoing similar vascular interventional procedures, relying on the radiologist's interpretation to identify any suboptimal image quality. Explanation: this scenario presents a professional challenge due to the inherent risks associated with radiographic imaging in vascular interventional procedures. Ensuring patient safety while obtaining diagnostic quality images requires a meticulous approach to technique selection and risk assessment. The ARRT certification in vascular interventional radiography (VI) emphasizes the technologist's responsibility in applying radiographic principles to minimize radiation dose and optimize image quality, directly impacting patient outcomes and adherence to regulatory standards. The correct approach represents best professional practice because it prioritizes a comprehensive risk assessment before initiating the imaging procedure. This involves evaluating patient-specific factors, the procedural requirements, and the potential for radiation-induced harm. By considering these elements, the technologist can select imaging parameters that balance diagnostic efficacy with radiation safety, aligning with the ARRT as low as reasonably achievable principle mandated by regulatory bodies such as the Nuclear Regulatory Commission, NRC, and state radiation control programs, which are foundational to ARRT certification. This proactive approach minimizes unnecessary radiation exposure, reduces the likelihood of repeat exposures due to suboptimal image quality, and upholds the ethical obligation to protect the patient. An incorrect approach that fails to conduct a thorough risk assessment before image acquisition is professionally unacceptable. This could involve defaulting to standard protocols without considering individual patient anatomy or procedural nuances, or prioritizing image acquisition speed over dose optimization. Such actions violate the ARRT principle, increasing the patient's cumulative radiation dose and potentially leading to deterministic effects or an increased stochastic risk. Furthermore, demonstrates a lack of critical thinking and adherence to the professional standards expected of a certified VI technologist, potentially leading to regulatory noncompliance and adverse patient events. The professional reasoning process for similar situations should involve a systematic evaluation. 1. Identify the imaging objective and the specific anatomical region. 2. Assess patient factors, e.g., body habitus, age, pregnancy status. 3. Consider the procedural context and the required image quality for diagnostic interpretation. 4. Evaluate available imaging equipment and its capabilities. 5. Select imaging parameters, KVP, M as filtration, collimation, pulse rate, that achieve the diagnostic objective while minimizing radiation dose, applying the ARRT principle. 6. Continuously monitor image quality and patient dose throughout the procedure, making adjustments as necessary. 7. Document all imaging parameters and any deviations from standard protocols. Question 18. Which approach would be considered the most comprehensive and safest method for pre-procedural assessment and preparation of a patient undergoing a vascular interventional radiography procedure, adhering to best practices and regulatory expectations? Option A. Focusing solely on the imaging studies related to the planned intervention, with less emphasis on systemic patient factors like medication history or recent lab work. Option B. Reviewing the patient's electronic health record for recent laboratory results, confirming allergies, verifying the correct procedural site inside, and ensuring the patient has been NPO for the appropriate duration. Option C. Performing a brief verbal check of the patient's name and date of birth immediately before entering the procedure room, with minimal review of other medical information. Option D. Relying on the referring physician's notes for a general overview of the patient's condition, and assuming no significant changes have occurred since the last documented visit. The correct answer is B. Reviewing the patient's electronic health record for recent laboratory results, confirming allergies, verifying the correct procedural site inside, and ensuring the patient has been NPO for the appropriate duration. Explanation. This scenario presents a common challenge in vascular interventional radiography, ensuring patient safety and procedural success through thorough pre-procedural assessment and preparation. The professional challenge lies in balancing the urgency of interventional procedures with the critical need for comprehensive patient evaluation to mitigate risks and optimize outcomes. Adherence to established protocols and regulatory guidelines is paramount. The correct approach represents best professional practice because it prioritizes a systematic and comprehensive evaluation of the patient's medical history, current condition, and potential risks. This includes a detailed review of laboratory results, imaging studies, and medication reconciliation, all of which are crucial for identifying contraindications, potential complications, and necessary interventions. This aligns with the ARRT standards for vascular interventional radiography, which emphasize the technologist's role in patient care and safety, requiring them to be knowledgeable about patient conditions and to contribute to a safe procedural environment. This proactive assessment minimizes the likelihood of adverse events and ensures the procedure is tailored to the individual patient's needs, reflecting a commitment to patient well-being and professional responsibility. An incorrect approach that neglects to review recent laboratory values, such as coagulation studies, poses a significant regulatory and ethical failure. This oversight could lead to a procedure being performed in a patient with an uncorrected coagulopathy, increasing the risk of hemorrhage, a direct violation of patient safety principles, and potentially contravening guidelines for safe interventional practice. Another incorrect approach that fails to confirm patient allergies, particularly to contrast media or medications, is also a critical failure. This omission directly jeopardizes patient safety by exposing them to a potentially life-threatening anaphylactic reaction, a clear breach of ethical duty, and a failure to adhere to fundamental patient care standards. Furthermore, an approach that does not verify the correct procedural site inside, especially in vascular interventions where laterality is crucial, represents a severe lapse in patient safety protocols. This could lead to a wrong site procedure, a sentinel event with profound ethical and legal ramifications, and a direct violation of patient rights and safety mandates. Professionals should employ a decision-making framework that begins with a thorough understanding of the procedural requirements and the patient's individual risk factors. This involves a systematic checklist approach to pre-procedural assessment, ensuring all critical elements, from patient identification and consent to medical history review, laboratory data, and allergy status, are meticulously verified. Collaboration with the interventionalist and nursing staff is essential to address any identified concerns before the procedure commences. This proactive and diligent approach ensures adherence to regulatory requirements and upholds the highest ethical standards of patient care. Question 19. The review process indicates a pattern of reduced visualization of distal arterial branches during peripheral angiography, leading to concerns about diagnostic adequacy. Which of the following strategies, when implemented by the VI radiologic technologist, best addresses this image quality challenge while adhering to professional standards? Option A. Increase the overall radiation dose by significantly raising the M, as for all subsequent peripheral angiography examinations to ensure brighter images. Option B. Systematically evaluate and adjust imaging parameters such as KVP, MS, and filtration in conjunction with optimizing collimation and detector positioning to enhance contrast-to-noise ratio and spatial resolution for small vessels. Option C. Rely solely on the radiologist's interpretation to identify areas of poor visualization, assuming that any missed details are inherent limitations of the imaging modality. Option D. Reduce the injection rate and volume of contrast media to minimize potential patient discomfort, without considering its impact on vessel ossification. The correct answer is B. Systematically evaluate and adjust imaging parameters such as KVP, MS, and filtration in conjunction with optimizing collimation and detector positioning to enhance contrast-to-noise ratio and spatial resolution for small vessels. Explanation. The review process indicates a recurring issue with image quality in vascular interventional VI procedures, specifically concerning the visualization of small vessels and subtle contrast ossification. This scenario is professionally challenging because suboptimal image quality directly impacts diagnostic accuracy and procedural guidance, potentially leading to misdiagnosis, incomplete treatment, or unnecessary complications. Radiologic technologists in VI are ethically and professionally obligated to produce images of diagnostic quality, adhering to established standards and protocols to ensure patient safety and effective care. Challenge lies in identifying the root cause of the degradation and implementing corrective actions within the constraints of radiation safety and equipment capabilities. The correct approach represents best professional practice because it involves a systematic, evidence-based investigation into the factors influencing image formation and quality. This includes a thorough understanding of the interplay between KVP, M as filtration, collimation, detector technology, contrast media administration, and patient positioning. By analyzing the specific characteristics of the suboptimal images and correlating them with potential technical or procedural variables, the technologist can isolate the cause. Adherence to ARRT standards for VI practice, which implicitly require the production of diagnostic quality images, is paramount. This approach prioritizes patient well-being by ensuring that the information conveyed by the images is reliable for clinical decision-making. An incorrect approach that focuses solely on increasing radiation dose without a targeted investigation is professionally unacceptable. This fails to address the underlying cause of image degradation and unnecessarily exposes the patient to higher radiation levels, violating the ARRT as low as reasonably achievable principle, a cornerstone of radiation safety regulations in the U.S. Another incorrect approach that neglects to consider the impact of contrast media characteristics, e.g., viscosity, injection rate, concentration, on opacification and visualization, overlooks a critical component of VI imaging, potentially leading to misinterpretation of vascular anatomy or pathology. Furthermore, an approach that dismisses the need for regular equipment quality control and calibration ignores regulatory requirements and best practices for maintaining optimal imaging performance, increasing the likelihood of persistent image quality issues. The professional reasoning process for similar situations should involve a structured problem-solving methodology. First, clearly define the observed problem e.g., or contrast enhancement, excessive noise, geometric distortion. Second, gather relevant data including image parameters, patient factors, and procedural details. Third, hypothesize potential causes based on knowledge of image formation principles and VI procedures. Fourth, systematically test these hypotheses through controlled adjustments or further investigation. Fifth, implement the most effective solution and monitor its impact. This iterative process, grounded in scientific principles and regulatory compliance, ensures that image quality issues are addressed effectively and ethically. Question 20. The analysis reveals that during a complex percutaneous coronary intervention, the radiographer observes that the contrast agent is not adequately visualized on the fluoroscopic images, leading to concerns about procedural guidance. The radiographer needs to adjust the X-ray beam to improve visualization without significantly increasing patient radiation dose. Considering the principles of X-ray production and interaction with matter, which adjustment would be most appropriate to enhance the visibility of the contrast agent? Option A. Increase the kilovoltage kVp to increase the energy of the X-ray photons, thereby improving their ability to pass through the patient and interact with the contrast agent, enhancing its visibility. Option B. Increase the kilovoltage kVp to improve beam penetration and reduce scatter. Option C. Increase the filtration to absorb lower energy photons and harden the beam. Option D. Decrease the milliamperage seconds m as to reduce overall radiation output. The correct answer is B. Increase the kilovoltage kVp to improve beam penetration and reduce scatter. Explanation. The analysis reveals a scenario where understanding the fundamental principles of X-ray production and its interaction with matter is crucial for ensuring patient safety and diagnostic image quality within the ARRT Vascular Interventional Radiography (VI) certification framework. This scenario is professionally challenging because it requires the radiographer to apply theoretical knowledge to practical situations, making informed decisions that directly impact patient outcomes and the effectiveness of diagnostic procedures. The ability to predict and control X-ray beam characteristics is paramount in minimizing radiation dose to the patient and staff, while achieving optimal image visualization for interventional procedures. The correct approach represents best professional practice because it demonstrates a thorough understanding of how altering technical factors influences the X-ray beam's energy and penetration. This knowledge allows for the selection of appropriate exposure settings that balance image quality with radiation dose, adhering to the ARRT as low as reasonably achievable principle, which is a cornerstone of radiation safety regulations in the United States. Specifically, understanding the relationship between kilovoltage, kVp, and the penetrability of the X-ray beam is essential for effective fluoroscopy and radiography in interventional procedures, where precise visualization of anatomical structures and devices is critical. This aligns with the ARRT certification's emphasis on the application of physics principles in clinical practice. An incorrect approach, such as solely relying on automatic exposure control (EEC), without understanding its underlying principles or limitations, fails to meet professional standards. While AEC can be a useful tool, over-reliance without comprehension can lead to suboptimal image quality or unnecessary radiation exposure if the system is not calibrated correctly, or if the patient's anatomy presents unusual attenuation characteristics. This could violate regulatory guidelines that mandate the radiographer's responsibility for image quality and dose management. Another incorrect approach, such as increasing milliamperage seconds, (M), as without considering its impact on beam quality, would lead to increased patient dose without a proportional improvement in image contrast or detail, demonstrating a lack of understanding of the interplay between beam quantity and quality. This directly contradicts the principle of dose optimization. Furthermore, failing to consider the inherent filtration of the X-ray tube and collimators when adjusting exposure factors demonstrates a superficial understanding of X-ray beam modification, potentially leading to an unnecessarily harder or softer beam than required for the specific interventional procedure, impacting both image quality and patient dose. The professional reasoning process for similar situations should involve a systematic evaluation of the imaging task, patient factors, and available equipment. This includes 1. Assessing the required image detail and contrast for the specific interventional procedure. 2. Considering patient size and composition to estimate beam attenuation. 3. Selecting appropriate technical factors, kVp, M as filtration based on an understanding of X-ray production and interaction with matter. 4. Utilizing AEC judiciously, understanding its limitations and verifying its performance. And 5. Continuously monitoring radiation dose to ensure compliance with ARRT principles and regulatory requirements. This iterative process ensures that diagnostic efficacy is maximized while minimizing patient and occupational radiation exposure, reflecting the highest standards of professional practice in vascular interventional radiography.